Hello, everyone, and welcome to another edition of Contagion. My name is John Parkinson, and I'm the senior editor. Joining us today is Dr. Rajiv Dhand, professor and chair of the Department of Medicine and associate dean of clinical affairs at the University of Tennessee Graduate School of Medicine. Thank you, doctor, for being able to join us today. Let's jump right into the topic. You recently published a paper titled Coughs and Sneezes, Their Role in Transmission of Respiratory Viral Infections, including SARS-CoV. For those not familiar with the paper, can you provide an overview of your research and what your conclusions were?
Certainly. So the major thing that we want with this paper is that coughs and sneezes are important means of transmitting viral respiratory infections, including SARS-CoV-2. And that, you produce a lot more droplets with coughs and sneezes, and they are of a size that could transmit the infection. The size of particles that are generated by normal breathing and, for example, speaking are small particles generated with coughs and sneezes, and they also arise mostly from a different part of the lungs. So that is the first thing. And the second message we wanted to convey with this study was that the major route of transmission for SARS-CoV-2 is with respiratory droplets, which are somewhat larger in size. For airborne transmission to occur, you need what are called droplet nuclei, which are actually dried respiratory droplets. So when the fluid evaporates, they become smaller in size, they become desiccated, and then they become like aerosols, and they form aerosols in the air, and they stick around for a long time. And such particles can cause airborne transmission, which occurs, for example, with measles and chickenpox. But fortunately for us, there is no documented evidence that such transmission, such airborne transmission is occurring with SARS-CoV-2. It could happen under certain special circumstances, spread. And so far as we know right now, the major method of spread is by respiratory droplets or by contact. And the third message we wanted to convey was that individuals produce very widely varying number of particles, even when they are sick or even when they are asymptomatic. There's a lot of variation in how many particles are produced by breathing, speaking, coughing, sneezing, and that we know that there are some individuals who produce a lot more of infectious particles than others, and these people could be super spreaders of the disease. What that means is that normally or usually most people will, infect maybe 2 or 3 other people, whereas super spreaders could infect a large number of people. And you see that happening with people go to a party, or they congregate for some function, and then many 20, 30, 40 people get infected, and that is generally the result of some person being a super spreader.
Okay. In the paper, you speak of aerosol generating procedures, or AGPs, such as intubation, bronchoscopy, and physiotherapy. Which of these AGPs put healthcare workers at a greater risk?
So let me explain what we mean by aerosol generating procedures, or AGPs. So these are procedures that will produce particles in the size that is small enough to be inhaled into the lung and deposit in the lung. So they could set up infection in the lungs, they could produce pneumonias. So such procedures are like intubating a patient or doing CPR on a patient or doing a bronchoscopy. Or another way that we can create aerosols is when we give therapies. For example, we try to avoid intubation by giving what we call high flow humidified oxygen to try and improve patients' oxygenation without having to put them on a breathing machine. Or we do it with masks, and that avoids intubation. But both these procedures do also create some aerosols in the environment that, you know, both that the people who are taking care or healthcare workers could inhale those particles and then become infected by that. To answer your specific question, any aerosol generating procedure where a healthcare worker is in very close proximity to the patient, for example, doing an intubation or doing CPR, then those carry the highest risk.
Okay. For all these AGPs, should healthcare workers be wearing all the same types of personal protection equipment, or do the protocols vary from AGP to AGP?
Yes, they vary. So, in high risk procedures that we talked about earlier, it is ideal to do them in negative pressure rooms where there is a much higher level of air exchange in those rooms. And the healthcare workers should be wearing gloves, gown, preferably a respirator and face shields. So we recommend N95 masks, and then for the most um, riskiest things like intubation, there may be what are called powered air purification respirators may have to be used.
Okay. In your paper, you discuss procedures for when using a ventilator. You mentioned instituting barriers to filter the virus or reduce virus dispersion by placing a filter at the exhalation port of the ventilator or connecting a filter to the oxygen mask. Is this something that's being done on a regular basis already?
No, it isn't done perhaps as frequently as it should be done, but this is the recommended way to try and reduce the dispersion of fugitive emissions, as we call them, into the environment. And you can't absolutely cut it off, but you can reduce it very significantly by adopting these methods.
For healthcare workers who are seeing COVID 19 patients in the hospital but are not undergoing any procedures that produce AGPs, what should these workers use in terms of personal protection equipment?
So they should use, the same gloves, gown, and mask. It could be, if there is no AGP, then they could even use a surgical mask. But if there is a risk of AGPs being used or patients getting nebulizer treatments, then N95 masks would be recommended. And of course, they should use them because you never know when there might be a splash of secretions. The person might cough or sneeze while the healthcare worker is in close proximity and get material on their face or eyes.